Okay, let's jump right in. We're tackling some really fundamental concepts today. We're pulling from material you shared with us about psychiatric mental health nursing. Our mission, basically to carve out the absolute core knowledge you need. We're talking about understanding patient admissions into mental health facilities and, maybe even more importantly, the fundamental rights those patients keep. And look, this isn't just, niche information for psych nurses. It's vital for anyone interacting with mental health care, really, professionally or even personally. The material we have gives us a really solid grounding, looking at these essential areas and guiding us through. We have our expert voice with us.
Thanks. Yeah, and it's definitely worth emphasizing up front. This knowledge isn't just for psych units, not at all. Understanding mental health conditions, the principles of care, it applies right across nursing. I mean, you will encounter patients with mental health challenges pretty much everywhere.
Everywhere.
Oh, yeah. In the ER, on med-surg floors, outpatient clinics, you name it. So having a firm grasp on these concepts we're about to discuss, particularly around, patient rights and the legal side of things, it really empowers nurses. It helps you provide better care and, honestly, navigate some potentially complex situations ethically and safely.
Absolutely. It feels foundational, doesn't it, for that holistic care idea. So, okay, the source material kicks off by outlining the different ways someone might actually enter a mental health facility. It lays out three main types of admission or commitment.
That's right. So the most, let's say, straightforward is voluntary admission. This is when someone makes a conscious decision, they recognize they need help, therapeutic support for a mental health issue, and they sign themselves in.
Okay, voluntary. And a really key point there is about leaving, right? Their ability to leave.
Precisely, yeah. Because they check themselves in, they generally have the right to request discharge and, check themselves out. It really underscores that principle of autonomy whenever possible.
Okay, that makes sense. They start it, they can generally end it.
Yeah.
But there's a catch, isn't there? A situation where that voluntary status can kind of shift.
Yes, and this really highlights one of the complexities the material touches upon. If a patient, someone who came in voluntarily, starts showing behaviors that indicate a significant risk, like harm to themselves or others, or if their mental state gets worse, to the point where they genuinely can't care for themselves anymore, what's often called being gravely disabled, then, yeah, the clinical team might need to initiate a process to change that admission to an involuntary status.
Which brings us right to the second type.
Yeah.
Involuntary commitment.
Exactly. This happens when a person, specifically because of their mental illness, is considered a danger to themselves or others, or is so gravely disabled they just can't meet their basic needs. The huge difference here is the person isn't consenting to being admitted.
Right. And the material points out this isn't just like a snap decision someone makes. There's a process involved.
Oh, absolutely. It typically requires a pretty formal process, often involving a specific legal framework. What seems consistent across many places, as the source notes, is the need for professional confirmation. Frequently, this means you need the assessment and agreement of, usually, two physicians. They need to agree that the criteria for involuntary commitment are actually met. They're essentially providing the clinical justification to override that person's immediate autonomy for safety reasons.
Okay, so it's based on assessed risk, inability to function, and it's backed by professional evaluation, often multiple professionals. And the material makes a really important note here about variation, state to state.
It does, and this is absolutely critical for anyone working in this field. The specific laws, the exact criteria used, even the number of physicians needed, and the overall steps in the procedure for involuntary commitment. It can vary significantly, state by state. You always have to know the legal specifics right where you're practicing.
State laws are absolutely key then. Got it. Now, the third type of admission discussed is more for, urgent situations.
That's emergency commitment, yeah. This is used when someone presents an imminent risk, like right now, an imminent risk of serious harm to themselves or others. Think of a real crisis situation where you need immediate intervention to prevent something terrible from happening.
Okay, so involuntary is for sort of established significant risk or grave disability, needing that formal process, while emergency is for immediate, right this second, urgent danger.
Precisely. Emergency commitment is designed for that critical, very time-sensitive scenario, immediate danger.
And the source mentions there's usually a pretty rapid follow-up required for these emergency commitments. You can't just leave it at that.
Yes, absolutely. Because you're intervening without the patient's consent in an emergency, the legal system demands a swift review. The material notes this usually involves a court hearing, often required very quickly, sometimes within, say, 24 or 48 hours, but usually within 72 hours. Again, depends heavily on state law. The whole point of this hearing is to figure out if that emergency hold was justified and whether the patient still meets the criteria to be kept involuntarily or if they can be released.
Okay, so recapping, voluntary is self-driven. Involuntary is for established risk or disability, needs professional confirmation, and emergency is for immediate danger, needing quick legal review. And the big takeaway for all of them is check your state regulations. They define the process.
Absolutely. It just underscores that need for healthcare professionals to be not just clinically good, but legally informed in their specific jurisdiction.
Now, here's where it gets, well, really compelling, and maybe a bit counterintuitive for some folks. The material strongly emphasizes that it doesn't matter how a patient arrived at the facility, right? Voluntary, involuntary, emergency hold. They don't just lose all their rights at the door. They keep certain fundamental rights.
This is such a cornerstone. Ethical and legal mental health care depends on this. The material highlights several key rights, and the first one is, well, it's crucial everywhere in healthcare, the right to confidentiality.
Which, as the source reminds us, is backed up by federal law. Things like I pay.
Correct, yeah. A patient's information is protected. It's private health information. It should really only be accessed and shared with people directly involved in that patient's care, disclosing it to others. That requires specific patient consent with very rare, legally defined exceptions.
And this is where one of those critical exceptions comes in. It creates a pretty significant ethical and practical challenge for staff, I imagine.
Exactly. The material discusses the concept of the duty to warn. This is a heavy one, a major exception. If a patient communicates a serious threat, like physical violence against an identifiable third party.
Identifiable, so not just general anger, but directed at someone specific.
Yes. The example given is like a patient stating a specific plan to harm someone when they leave the facility. In that case, the healthcare provider has a professional and legal obligation to take reasonable steps to protect that potential victim. This might mean warning the person directly, or notifying the police, or taking clinical actions to prevent the harm.
Wow, so patient privacy is huge, but the duty to protect others from imminent harm can, in these very specific situations, override that confidentiality. That must be an incredibly difficult line for clinicians to walk.
It really requires careful clinical judgment, and it often involves consulting, with the whole treatment team, maybe legal counsel. It's a direct clash between two really important principles: protecting the patient's privacy and protecting potential victims. The material stresses that safety takes precedence in these specific high-risk scenarios.
That makes the weight of that decision very, very clear. Okay, what's another fundamental right that's outlined?
This next one. It's often surprising to people, as the material points out. Especially when you think about involuntary admissions, it's the right to refuse treatment.
Wait, really? So even if someone is committed because they're considered a danger or gravely disabled, they can still say no to medication or therapy?
That is a core principle that's highlighted, yes. The material explains that a patient keeps the right to refuse recommended treatments, even psychotropic medications, unless there's a clear legal justification, like a court order, to treat them over their objection.
How? How does that work in practice? I mean, if you have someone committed because they're unwell, potentially dangerous, but they refuse the very treatment that's supposed to help them become less so.
This is where those complexities the material describes really show up. The nurse's role here is absolutely crucial. It involves a lot of therapeutic communication, explaining why the treatment is recommended, the potential benefits if they take it, the potential risks or consequences if they refuse. It's about making sure the patient is informed as much as possible, even if their illness is clouding their judgment. But ultimately, unless there's a specific legal order or a true emergency, their refusal has to be respected. It really underscores the high value placed on individual autonomy, even within a system designed to step in when autonomy seems compromised by illness.
That truly highlights the ethical tightrope they walk. But, okay, like the confidentiality exception, there's an exception here too, right? It's not absolute.
Yes, the material clarifies that. The right to refuse treatment isn't absolute in all circumstances. Just like confidentiality can be overridden by the duty to warn in an emergency threatening others. The right to refuse treatment can be overridden in an emergency situation where the patient's behavior poses an immediate, serious risk of harm to themselves or others, right now.
So if a patient is becoming violent or maybe actively suicidal in that moment, and refusing medication is preventing the team from ensuring immediate safety.
Exactly. In that kind of acute, dangerous crisis, medication or other necessary interventions might be given against the patient's immediate refusal. And this is critical only for the purpose of restoring immediate safety, and only for the duration of that specific emergency. The material really stresses this is a critical safety measure. It's not a routine way to override their right to refuse. It's temporary for an immediate crisis.
Okay, so autonomy is deeply respected, but immediate safety for everyone involved can, and sometimes must, take temporary precedence in a crisis. What's the third fundamental right the material discusses?
The right to treatment in the least restrictive environment. This principle is all about making sure that interventions that limit a patient's freedom or autonomy, things like restraints, are used only when absolutely necessary, and they have to be the minimum required to ensure safety and allow treatment.
This relates directly to things like physical restraints or seclusion rooms, correct?
It does, yeah.
Oh.
The material highlights that measures like physical restraints, chemical restraints, using medication primarily for behavioral control, or placing a patient in seclusion. These should always be considered last resorts. There are significant restrictions on a person's liberty.
And not just a last resort, but used for the absolute shortest possible time needed.
Absolutely. The material emphasizes exploring all the less restrictive options first. Things like de-escalation techniques, verbal redirection, maybe offering PRN, as-needed medications proactively before things escalate. Try all that before resorting to restraint or seclusion. And if they are used, they have to be applied safely, the patient needs continuous monitoring, and they have to be stopped as soon as that immediate safety risk has passed. The goal is always, always to maintain as much of the patient's freedom and dignity as is safely possible while they get care. It's just another facet of that constant balancing act, safety versus patient autonomy and rights.
It's really clear that this balance, this tension, and it's a recurring theme running through all of these concepts. Respecting rights while ensuring safety. It's always there. So let's just quickly recap. We've navigated the different ways into care: voluntary, where the patient seeks help; involuntary, when risk or disability means intervention is needed, backed by professional confirmation; and emergency, for immediate danger requiring that quick legal review. And the crucial detail running through all admissions is how much state laws vary.
Yep. Those state specifics are absolutely non-negotiable knowledge for practitioners.
And then we really got into the fundamental rights patients keep no matter how they were admitted. Confidentiality is so vital for trust, but with that serious duty to warn exception for imminent risk to a specific person.
A very difficult but necessary ethical carve-out.
Then the right to refuse treatment, maybe one of the most striking points, that even involuntarily committed patients generally hold this right, which challenges healthcare providers to really communicate and inform, while also recognizing that in an immediate critical emergency, safety measures, including needed meds, might be required.
Exactly. Balancing that deep respect for autonomy with the need for immediate crisis intervention.
And finally, the right to the least restrictive environment, really pushing clinicians to try everything else first before using things like restraints or seclusion, and then only for the briefest necessary time.
These concepts really are foundational, aren't they, for understanding mental health care practice and just the whole ethical landscape clinicians navigate every single day. As the material kind of implicitly suggests, grasping these nuances, it takes thought and practice applying it. What really stands out for me looking at this material again is how these principles consistently reinforce this idea. Even when someone is getting mandatory treatment because of their illness, their inherent worth, and as much of their autonomy as is safely possible must be preserved. The exceptions to these rights, duty to warn, emergency treatment, they aren't just loopholes. They're meant to be narrow pathways defined by immediate, serious safety risks. It represents the system trying, however imperfectly, to balance individual liberty with collective well-being.
It certainly presents a profound challenge for healthcare professionals. Just think about the responsibility of deciding when that duty to warn threshold is actually met, or the difficulty of upholding a patient's right to refuse a treatment you genuinely believe could be life-saving, versus recognizing that precise moment an emergency intervention is necessary to prevent immediate harm. It's huge.
And this raises, I think, an important question for you, the listener, to consider, drawing from the material we've just explored. Given the really significant emphasis placed on the right to refuse treatment, even for those admitted involuntarily precisely because their judgment is impaired by illness, what does this tell us about the core values that underpin our mental health care system? And maybe more practically, how do clinicians make those real-time, incredibly high-stakes decisions about where the boundary of that right truly lies when faced with a crisis?
That's a lot to process. And, the material does touch upon another related concept, which builds right on some of these rights discussions. It might be a really fascinating deep dive for us in the future. The whole intricacies of informed consent, specifically within mental health settings.
Oh, definitely worth exploring further. Something to keep in mind. Stay tuned.